Is there? Yes, I saw him before.
Okay, good morning and good afternoon and maybe good night in the East. Can you see me and hear me?
Yes.
Yes, we hear you and we saw your slide. And I don't know if everybody's, but I saw the slide.
Thank you very much, Dr. Brody, as moderator, and thank you to the leadership of this wonderful WFNS Neuroanatomy committee. Thank you for the invitation. I'm going to speak about Petrous Apex, neuroanatomy and surgical approaches. I think that I have little to add to the wonderful presentation of Sebastian Froelich and also the wonderful cases of Atul Goel. But anyway, I will just go over the anatomy and some cases. Just top left, you can see in this slide from Vinko Dolen, you can see the Petrous bone, the Petrous apex itself, the anterior Petrous apex, because we have an anterior Petrous apex and posterior one that is just behind the internal auditory canal. And we also can see the relevant neuroanatomy, neurovascular structures, B3, B2. This is the Gessiran ganglion, superior petrosal sinus, Petrous carotid artery, and GSPN. Important to mention that very frequently, and as in this case, Petrous carotid artery can have just a very thin layer, only just covering this Petrous segment, so we can provoke some disaster if we are not aware of that. Just top right, we can see the trigeminal ganglion, the division, the relationship with the real internal, with the real cavernous sinus, and also the Petrous apex. In this wonderful slide, I'd like to thank Pablo Gonzalez and his team of the 3D Neuroanatomy Lab in Alicante, Spain, for giving me this wonderful anatomical slide. We can see the way we could get inside the Petrous, we can get inside the posterior fossa, and I think that Sebastian Froelich showed a very nice example of how to get inside the brainstem through the Petrous apex. And now we can see this more complex neuroanatomical view of the Petrous carotid artery, inferior petrosal sinus after drilling. We can see the dura of the posterior fossa. We can see the sometimes difficult relationship with the trigeminal nerve. This is the segment, the intracisternal segment, content of the internal auditory canal, and this is the fourth nerve, the sixth nerve. In summary, we are not only talking about the Petrous apex, the Petrous bone, but also about the Petrous apex area that is, to my knowledge, very, very complex. We can start with the role of microsurgery, and I think that the step has been mentioned. We have to do a zygomatic osteotomy or cranio-orbitozygomatic osteotomy. We usually do not a cranio-orbitozygomatic approach, just in case a zygomatic osteotomy, because the only usefulness is the possibility to reflect downward the temporal muscle, just diminishing the retraction of the temporal lobe. We have to identify laterally the middle meningeal artery and the third division of the trigeminal nerve, the peeling of the trigeminal nerve complex, that is some incorporation to that kind of surgical skull-based approaches coming from the 80s. And after this peeling, and at the same time, we have to preserve the GSPN and also, of course, identify and preserve the Petrous carotid artery. We can go to the first division of the Petrous apex region, the first lesions that are particularly restricted to the Petrous bone. The typical example is cholesterol granuloma, we also have chondrosarcoma, we also have primary cholesteatoma in this area. We can make a simple incision. We can do just this limited zygomatic osteotomy in case you have a very bulgy temporal muscle that is going to make difficult your retraction of the temporal bone. You can do a very small craniotomy, and this is the way you can identify the third division, second division, trigeminal ganglion. This is dura mater. We have just started to see the cholesterol granuloma with its typical appearance. This is Petrous carotid artery, and this is GSPN that has, as mentioned before by Sebastian, a very broad course, and sometimes is difficult to be identified, mainly in all patients with very sticky dura to the bone. And this is the way we can make the exposition and very easy removal. This is a cholesterol granuloma we operated on more than 25 years ago. You can see how CT scan is leading you to the relevant anatomy, and you cannot need neuronavigation for that kind of very easy to identify lesion. This is the way we used more than 25 years ago to identify the lesion, identify Petrous carotid artery, and for complete resection of the lesion and full exposure of this is the first loop of carotid artery, Petrous segment, second loop right before getting inside cavernous sinus. The only way of just having this view is cutting the third division of the trigeminal nerve. We used to do that more than 25 years ago, and after that we used to suture with the hope of having some good recovery. In any way, this is the resection, the view of the anatomical field, surgical field after resection. But for those that think that cholesterol granuloma is a very indolent lesion, see what happened with this patient. He was lost for follow-up, and the patient came back last time to Malaga, because this operation was done in Granada, my former institution, and you can see this huge lesion as view after CPA angle approach. These are lower cranial nerves. So be very much aware of the possibility of recurrency in cholesterol granuloma. Chondrosarcoma is another typical lesion. You can see the CT scan, you can see the MRI, and the way you can do this transpetrous resection, the way we have shown before, and following these surgical steps. This is another chondrosarcoma. You can see the moment the lesion is breaking the dura mater and getting inside CPA angle, and this is after transpetrous resection, removal of the lesion. Second group of tumors and lesions are located at the extradural interdural space. This is basically lesion related to the trigeminal ganglion. You can see this patient. This is a psychiatrist from Malaga who was complaining of intermittent headache, facial pain, and diplopia. You can see the lesion. You can see the both layers, and inside trigeminal ganglion with this appearance. And this is the very easy way you can do some extradural approach. I think that this slide is showing the relevant anatomy for the youngest colleagues participating in this webinar. You can see the trigeminal nerve. You can see the trigeminal ganglion that is inside Meckel's cave. You can see porus trigeminalis, that is the opening where the trigeminal nerve is getting inside Meckel's cave and just convert into trigeminal ganglion. And trigeminal cister, that is variable according to anatomical factors, maybe absence or maybe hue. Trigeminal cister is expressing the CSF around the content and nervous content and inside Meckel's cave. So what we have to do is just some extradural approach, lifting neuromatic and showing trigeminal nerve. But important, first of all, that we will find many different interpretation and many different publication, epidural, interdural, frontotemporal approach. We can show this very important paper published in 1995, infratemporal fossa interdural approach, that is one of the best, showing this interdural way of exposing and removing trigeminal neurinoma, and Atul Goel just showed us many examples. In any way, many different reference to one single concept, that is the extradural approach. But as Sebastian mentioned, we have to be very much afraid of the venous anatomy, quite variable at the temporal fossa. We have to see that we can have very prominent sphenobasal veins and infratemporal veins very frequently going around the third division of the trigeminal nerve, making this extradural approach very troublesome due to the bleeding. Now Flocil is easing many operations. Before that, it was in sometimes like a nightmare. You can see one of the anatomical slides from Pablo González and his colleagues' anatomical lab, and the way the venous is around the third division. And you can see the sphenobasal and temporal veins, and you can imagine what happened at the extradural approach, a lot of bleeding. So in cases like that, you only have to open the dura, reflect very carefully after releasing CSF by means of spinal drainage or just opening cistern, and that way you can show the lateral wall of the cavernous sinus, this bulgy image, and the very easy way you can remove the tumor, and in this occasion, fortunately, preserving the fibers of the trigeminal ganglion. So you can see another trigeminal neuroma, that is the dominant pathology when talking about interdural lesions at the lateral wall of cavernous sinus. And this is the easy way you can do if you have some problem. Extradurally, you can open dura and expose the lesion, as seen here. And the way you can, in this case again, fortunately preserve the second and third division of the trigeminal nerve. Not always possible, by the way, according to the case by case. Now we can go to the third category of lesion at the Petrous Apex area, Meckel's caves area, that are extradural and intradural lesion. I very much recommend to the youngest colleagues just to read this article published in 1999, Dr. Yoshida and Kawase. You can see them in Bali 10 years ago in a meeting. This is about trigeminal neurinoma extending into multiple fossa. You can see this very nice view that is showing the way maybe trigeminal neuroma is the only lesion at the same time can be intradural and extradural, at the same time can be intracranial and extracranial. So according to the caprice, you can have many combinations, but in any way, it's important to mention that this sort of extradural or intradural approach is very useful to remove not only the Petrous Apex component, but also the component inside posterior fossa. Atul Goel showed many examples. Sometimes you have to coagulate, or you need to clip according to the caliber of the superior petrosal sinus, and that way you can have some more easy way to make the removal of the lesion. This is the third nerve preserved. In that case, the fourth nerve was damaged during the approach, and very important, if you have to coagulate or clip the superior petrosal sinus and cutting tentorium, do not do it just closer, 1 centimeter closer to the clinoidal area. If you do that, you will for sure damage the fourth nerve. This is one of the rare instances we have done COC, cranio-orbito-zygomatic approach. This is a lesion of the trigeminal nerve that at the same time is extending into the orbit following the first division of the trigeminal nerve, the way we do not only the craniotomy, but also the COC craniotomy that, although described in the 90s, must be avoided in many cases. This is the exception because it's a very time-consuming and morbidity-provoking approach, not necessary. This is the way we did that. We left some small remaining tumor here at the superior fissure, trying to preserve in as much as possible the function of the oculomotor nerves that already were damaged, by the way. And this is the way, in this particular case, and due to the histology, the lesion did recur in the way you can see here again, after this nice initial removal. You can see the recurrency of the lesion inside the orbit, inside posterior fossa, inside trigeminal ganglion. So we went again through transcranial approach with some slight modification. You can see the way you can get the whole tumor just following the way the tumor is leading, is providing for you. This is the vertebrovascular artery, and this is the way, by means of combined endoscopy, we managed to remove the intraconal, the intraorbital content without COC, just using the endoscopic tool attached to the kinevo microscope. This is the last slide after this operation, done maybe 1 year ago or something like that, with complete removal of the lesion, including the content of the orbit and, of course, the lateral aspect of cavernous sinus. This is another lesion recently operated on with rapid growing in an 18-year-old patient. You can see the lesion getting inside posterior fossa, and no matter how big the lesion is inside posterior fossa, this approach, anterior petrosal approach, following the tumor, you can get the whole lesion, including the content at the posterior fossa. You have to cut the tentorium a little bit, and you will have a very nice exposure of the lateral aspect of the brainstem and also the anterior aspect of the cerebellopontine region. This is a CT scan immediately after removal of the lesion. Histology, meningioma, clear cell meningioma that is going to be sent to radiotherapy. And this is another variation of the anterior petrosal approach and Petrous Apex, microsurgical Petrous Apex surgery. This is the extended middle fossa approach. Extended middle fossa approach is including the Petrous Apex drilling, as shown before by me and also Sebastian, but we have to add several dural osteotomies, coagulation, and section of the superior petrosal sinus, so that way you can get inside posterior fossa. This is one of the pictures of the publication in 1991 by Dr. Sekar and Dr. Sen. This is showing the way you can drill and get inside and have access to the petroclival and posterior fossa region. I have to mention that, to my mind, there are few indications for this approach, that this is not an easy approach, that is, as always, very much relying on the anatomy and the size of the Petrous Apex that is quite variable. And there are 3 indications. Of course, one of them is meningioma. To my mind, I don't see many indications, although this approach was popularized by Professor Kawase with the main indication of meningioma. Second indication could be, as shown by Sebastian Freilich, anterolateral pontine tumor, typically cavernous angioma. This is a second indication. And third indication, and to my mind, the main indication, lesions that are growing at the same time at the Petrous Apex and also inside posterior fossa and petroclival region. So we can see chondrosarcoma, one of the typical examples for that. This is a young patient with multiple cranial nerve palsy. You can see the lesion displacing carotid artery involving Petrous Apex, getting inside posterior fossa, distorting brainstem, and this is one of the good indication to my knowledge. This is.
Miguel, you have 2 minutes.
Thank you. I will finish in 2 minutes. This is the fifth nerve, and this is the way you have to identify middle meningeal artery. In that case, middle meningeal artery and third division of trigeminal nerve were together. One single unit we have to identify and spare one from the other, as you can see here. Then you have to do the peeling of the trigeminal nerve. This is GSPN, this is middle meningeal artery, just cut, and we are just exposing the Petrous Apex. Until which extent you have to do the peeling and you have to expose the Petrous Apex. You have to do that until you are able to just go around with your dissector, as you can see here. Next step is just drilling the Petrous bone. In that part of the operation, the Petrous bone is completely normal. You will see how the drill is getting inside deeper, inside more easily. In this moment, this is the softer infiltrated bone. Move around. This is the petroclival dura. We just remove the tumor. Be very much aware of the possibility of damaging the cochlea and also the possibility of damaging the inferior petrosal sinus, whose anatomy is variable and may provoke some troublesome bleeding, as mentioned earlier. And we can see after drilling of the bone, this is dura mater, this is internal auditory canal dura mater, internal Petrous carotid artery. And if you want, this is the third division of trigeminal nerve and trigeminal ganglion. If you want to see the real petroclival junction, you cannot do that unless you cut the fifth nerve or use endoscopy. And this is the way, with the aid of endoscopy, you can see some remaining tumor over here that can be drilled and removed. And this is, as mentioned earlier, you can see the way you have to do a parallel cut of the inferior surface of tentorium and dura. Okay, you can see the trigeminal ganglion. Let's move to the next one. We are coagulating. You can see the cisternal segment of the fifth nerve. You have to be very careful with when cutting tentorium and dura, because usually the fifth nerve is very close to the dura, and this is the way you are exposing the nerve protected by cottonoid. We have pushed away part of the bulgy tumor at the CP angle and petroclival region. We can drill that. And with the CUSA, you have to remove. And this is the final step. This is the fifth nerve. This is the anterolateral pontine region with some sticky tumor over there that is very carefully removed, trying to avoid damage to the brainstem. You can see not very good plane, so you have to be very careful in cases like that. And this is the pre and the postoperative MRI after removal of this chondrosarcoma to this approach. This is another case, a chordoma. I will move.
You have to go to the conclusion.
Yes, conclusion, thank you. Just some, you can see how you can make the choice for microsurgery or endoscopy, taking into account whether the lesion is a butting, a sphenoidal sinus, that makes the lesion very easy to be removed, whether or not intradural growing, how far and how posterior the lesion is, whether or not there is vascular encasement and extension to jugular foramen. You can see just below and right, bottom right, the fight between endoscopy and microsurgery. You don't have to do that. You have to be frank and combine both techniques. And that way, knowing anatomy and knowing about some surgical steps for microsurgery and endoscopy, I didn't deal with that. You can get access to the Petrous bone, petroclival region, pontine region, lateral wall of cavernous sinus, and also infratemporal arteriopalatine fossa in case you do endoscopic approach. Thank you very much.
Thank you, Miguel. There is any question or comments? I don't see any question from the floor. All the panelists have to make comments. If not, may I make a comment? I think that the previous lecture and your lecture are showing as this kind of approach should be tailored for each pathology and this patient. It's not a standard approach, it has to be validated by what Floris say, the pre-op navigation to understand what we are going to do and to choose the right patient, both for endoscopy, both for microscopic. That's my contribution to this beautiful lecture that we have. Any other comments or question?